On the road. It is 1:30 and we will call to order the Cumberland County Finance meeting. And we'll begin with a roll call, please, Desiree.
Commissioner Nieder.
I am here.
Commissioner Fauci.
I'm here.
Commissioner Eichelberger.
Present.
All right, we are at the point of the agenda where we open the floor up to public comment. Is there anyone in the room wishing to make public comment at this time? I think we're here for some other good stuff, but public comment is not one of them. Desiree, is there anyone showing online? If you're online and would like to make a public comment, please use the raise your hand feature.
No request at this time.
None? All right, very good, thank you. We'll entertain a motion for the approval of the minutes of September 10th.
So moved.
Sorry.
It's moved and seconded. All in favor say aye.
Aye.
Aye. Thank you. Now, best part of the agenda. We get to acknowledge an employee, Shelley Gettle, who's been with our MHIDD department for her 25 years of service. And we have Mark Evans here. We'll bring him up, take some pictures, do the presentation, and get to hear maybe a little bit about Shelley's history over the past 25 years.
She's been here so long, I had to bring notes.
Thank you.
So if I
Please,
could, yeah. So this one's really special to me. Shelley and I actually started 3 weeks apart from each other back in 2000, both as case managers, which are now called supports coordinators. She was also my very first person I hired as a supervisory position when I became the SEO director in 2003. Later, she did move on to our administrative entity side of the county and has been a program specialist there since around 2008, 2009. She oversees some really behind the scenes functions of our office, but they're really, really important because they all really boil down to quality supports, quality services, and making sure that the individuals and families that we're working with are satisfied with those services. So Shelley's also a lifelong Cumberland County resident. And before she came to the county, spent about 4 years with one of our providers working in residential services. And we're really lucky to have Shelley as part of our team and very appreciative of all of her work that she's done over the years. So thank you, Shelley.
Thank you. Absolutely.
Shelley, the question I usually ask, 25 years, are we good for 20 more?
That's a good goal. We'll aim for that.
Okay, we'll take a few formal pictures and then go on.
I'm gonna take several. Thank you.
Thank you. Thank you very much.
Thank you.
All right. Next, we have several agenda items. We are going to have a discussion and possible motion to approve the DCED local share account fund category 4 request that we are making an application. We have Katie Zimmerman, our grants coordinator, and I see some folks here to support her in this effort. Okay.
So we are here seeking your approval to apply for just over $132,000 for the LSA Category 4 grant. This will be for body-worn cameras for the sheriff and prison. The total project cost is $310,000, and the portion we're asking for the grant funds is the allowable portion from DCED, which is like the equipment, like the cameras themselves, chargers, things like that. The rest is software and video storage. And we're all here, as you can see, to answer any questions you might have. But before I do want to just kind of give some shout outs to folks. Trevor and Sergeant Bureau did an incredible amount of effort of work to look through all of the different cameras we could buy, see what would be the best fit, and also figure out, once we get the cameras, what's the best way to deploy them, what policies do we need, how can we do training and things like that to make sure we're really making a thoughtful decision for both the sheriff's office and prison. IMTO has been part of our team, making sure that once we get all this footage, are our systems ready to handle it? Are the people who need to be able to access that footage going to be able to access it? Public safety chimed in to make sure that the cameras we were purchasing would be a good fit with the larger P25 project. And the prison board has been a part of making sure this is a good fit as well. So yeah, we are all here if you have any questions, or if anyone else from the team wants to say anything about the grant or the project.
Certainly takes a village to pull this together. The only question I would have, and I don't know if it may be directed more to the folks at the prison or in the sheriff's department, but the lifespan on these cameras, and is this just a typical course of doing business nowadays in the line of business that you guys are in? Are other jails and other sheriff's departments utilizing this technology?
Yes, ma'am. So body worn cameras it's not a matter of if, it's a matter of when. There's no scenario where we don't implement them. This is just this is the best time to do it because of the grant opportunity, and because the bulk of the remaining money is eligible for our canteen fund. So to speak to the lifespan of the technology, we've worked that to the agreement with the vendor that after 2.5 years, we upgrade to the highest model at no charge. It's part of what the contract would state. So we will always be up to date. The body cams that the sheriff's department is getting are compatible with their new radios. So if they were to respond to a call, they wouldn't have to be concerned about manually turning on the radio. As soon as their radio goes, the camera turns on. So it enhances the ability to keep our sheriff safe, our correctional officers safe, and the people that we come into contact with as well.
Yeah, all of our employees in this building.
Yeah, it's perfect timing with the new portable radio systems that are coming out, because the ones that we ordered are compatible with the top of the line SVX body cams that will be able to Bluetooth to that portable. They wouldn't be able to do it to these portables here, but they will be able to do that to the new one. So it's like perfect timing.
Okay, wonderful. I appreciate you all putting the effort into this, and we'll cross our fingers and hope that we can get the necessary funding to make this happen. So thank you, Katie. On that, did you have any questions? Either of my colleagues, Gary in the room, Commissioner Bashi online?
Covered pretty well in the briefings. It's Gina's.
Commissioner Bashi, did you have anything you wanted to ask or add?
I don't. I think that we've been briefed on this several times very well, and I am driving, so I'm
okay.
going to stop talking.
Well, drive safely. Okay.
I'll make the motion.
Thank you. There's a motion. Is there a second?
I'll second.
Okay, it's moved and seconded. All in favor say aye.
Aye.
Aye. Thank you. Next up, Katie, I think you're still at bat here.
Also, another shout out is to Angela and her team for making sure that all of this get on the agenda appropriately. So this is the resolution to be able to do all of the paperwork and e-grants to apply and then accept.
Okay, very good. Thank you. If there's no other questions, I'll entertain a motion.
Move to approve.
Second.
It's moved and seconded. All in favor say aye.
Aye.
Aye. Thank you. Now, I believe we have a team from our drug and alcohol department that will be doing an update on the opioid settlement funding. So Brenda, Morgan, I'm not sure who all's gonna come on.
Ryan will be part of the presentation, Rebecca and Morgan.
Okay, perfect. If we need to pull up more chairs, just pull them on up.
And you could stay here part of this too. This one takes a team.
I'm really finding just about everything done.
Yeah, you betcha. It's pinky. Is it gonna show? Oh, okay.
The one always has the software.
Okay, well, this is our 6-month update to the commissioners. As you may remember, we do a report to the trust, the opioid trust, every 6 months, and then we submit to do an update for you, so you know how our Cumberland County funds are going. Our overall mitigation philosophy, if you will, was to reduce the oversupply of prescription meds on the streets. That has definitely happened. A lot of that has been through legislation and other means besides the trust. Increase the access to naloxone, increase the access to opioid use disorder treatment, expand prevention and early intervention efforts, and then partner with criminal justice to support diversion programs and recovery efforts. One of the good pieces that I have to report this go round is overdoses are decreasing nationally. They went down 27% in Pennsylvania in the last from 2023 to 2024. They went down 29%, which is even greater. And in Cumberland County, we are at 29% between those 2 years. Also, looks like we were currently at 19, we were at 28 and 24. So I don't know that we're going to see a significant decrease this year. The bad news is there's still people dying and because of the drugs on the street and the overprescriptions that we still see. Morgan and I had the gift of attending an overdose awareness month event recently. As you are aware, the commissioners here have said that September is Recovery Month. A piece of that also is Overdose Awareness Month. And we were at the state capitol, and it was really touching to see behind all these numbers I'm giving you today were faces, and their families were there, and just hundreds and hundreds and hundreds of faces that had died because of the opioid overdoses. More locally in Shippensburg, we were able to attend an event which was very touching. Also, they had 160 pictures submitted from local people of just wanting to be remembered, that had died from overdoses. So hopefully that makes this presentation a little more personal to folks. These are people in our communities that are dying or have died and are being remembered. As you may remember, all of the funds have to go through Exhibit E, which is pretty structured. The commissioners decide if the funds are, what goes where. The counties have a lot of power with this trust, which is great. And so it's trying to be more local. And then we also have to be approved by the trust eventually. But if it's within Exhibit E, it's pretty likely to get approved. We have 6 programs within Cumberland County that have been approved already. This is the biannual report to the commissioners. Some good news is there's 2 more funding sources that some funds will be coming. We don't know the details yet, but what we do know is the Purdue-Sackler settlement has went before the entities, and Cumberland County has signed on. So we will be and I know Keith has worked with you on that, and that we're well within timelines and have signed on. And then there's also 8 generic opioid manufacturers that have come together in one lawsuit, and they're calling themselves the secondary manufacturer settlement. And we have signed on to that one too. So what we should know in first quarter 2026 about how much money we're getting, and we should be, and then of course we'll come to you to do presentations, and it'll have to be under Exhibit E, similar to the other ones. And then we should be seeing the money in 2020, late 2026 is what we're hearing. So our hopes are that other entities will sign on, because if they don't, it's all null and void, and back to the drawing board we go. So yeah, one of the pieces that we were able to see, though, as part of this settlement is there's going to be some tight monitoring of the opioid pharmacies in the future. So hopefully we'll never get in a mess like this again because of the tight monitoring that they're doing. Another piece that is
Excuse me, Brenda, is that nationally?
Yeah, those are
Nas-
national.
That's
Those are
nationally, they're going to be, it's not just Pennsylvania
No,
where they're
no.
going to be monitored. Okay, thank you.
Yeah, absolutely, yeah.
Do we know anything about the safeguards that are in place for legitimate prescriptions? Because when they've done these monitoring things in the state, it has led to real difficulty for people getting medications that they need
Yeah.
and deserve.
Yeah.
So is the monitoring, have they learned anything from the problems it created originally?
I'm not an expert on that, but very much aware that people with pain have at times not gotten what they need because of it, which is hopefully a learning for the pharmacies and for the docs and for everybody, but it's monitored pretty tight.
Hopefully it's a learning for the people who are writing the regulations.
Yeah, absolutely.
Okay, thank you.
There is a new website out there for the public because there was a lot of concern about the transparency of the trust. And so I want to just put that before the public that the new website is called, the address is listed on the PowerPoint, but I'll read it out loud, paopioidsettlementdata.org. And that is very transparent. You can look at any county, see what they're spending their money on, how much, descriptions of the programs. This was done through the trust using Penn State, University of Pittsburgh, and Temple University to just really help them to become much more transparent. There's also been the first public listening session, which happened recently, and there were several folks that spoke publicly. One was a public defender who said, we need some of this money for police departments because we are using police to help people get treatment. As you may remember, it can't be used for law enforcement efforts, but it can be used for helping people get treatment. And then Jeff Hanley, who's the head of prevention for the state of Pennsylvania, said, we need to do more prevention too. We need more money there. Luckily, Cumberland County is already ahead of that by supporting prevention efforts. And then the most touching were individuals and their families who are saying, we'd like to be heard more and be served better. So the good news is the trust is opening up to listening to folks in the communities. But very recently, these are the 6 programs that are funded by Cumberland County opioid trust funds, and you can see the numbers there. And we'll break it down a little bit more so you can hear more about each program. And Rebecca's going to speak to us about the prison.
Okay. So we've spent, I guess, $359,972, and that largely goes into the salaries that Prime Care requires to run the program, the MAT program inside the prison. I did want to highlight this time, though, the importance of the RAISE project and the 2 certified recovery specialists that work with us. They're in the prison pretty much 5 days a week. They run groups by our units, our sister units, because we're still running groups that way since COVID. But they sit people in the MAT program down each week. They're working on recovery skills. They're working on planning for when they're released. They assist them with all kinds of things that they're going to need to have set up once they leave. And then prior to release, they're doing intakes for them to become part of the RAISE project on the outside. And so they've followed in this 6 months 37 people who are Cumberland County residents from the prison to the community. And they continue to work with them also on the outside. So they're very integral to our success. And we've found that the people who remain engaged with RAISE are far less likely to relapse and come back. So for this 6 months, we've also, I think, inducted 57 people. Sorry, 55 people. Okay, 55 people. we've only, I think I said 57 because we did do intakes on 57, but we did deny 2 people who did not meet criteria. When I say do not meet criteria, it's that they have asked to be on MAT, but there is no history that we can find that they've ever been involved with opioids or alcohol. We have access to a database that says if they've ever, been prescribed an opiate or been prescribed an MAT, we look through all of their criminal history to see if there was ever any kind of arrest. We're just very careful because we do find people that want to just be on it, perhaps to be able to be high while in prison. If a person does persist that they have a problem, we will wait till 2 weeks before they're released, potentially if the doctor signs off on it, and prescribe it to them then, so that just in the off chance they're safe in the community. But we have to really balance what is a medical need against our security needs, because the biggest problem that we do have inside the jail is diversion. Any other questions about
Just the
how?
requirements of them remaining engaged with Raise, is that something that a parole or probation officer can insist upon as part of their exit plan?
I suppose that it could be, if they deem that part of their treatment. I mean, it's medication assisted treatment. So within the jail, if they want to be in the program, we require that they participate in things. And we keep track every day when there's a Raise group or a session with Amanda Kramer, the MAT counselor. If a person misses, we keep track of that. We'll follow up with them. If they miss 3 things, we'll indicate to the doctor that they're not actually participating in their treatment. They'll get a counseling session. So we do as much as we can to keep them engaged. But what they do once they leave, and we also have other people in the program who aren't necessarily Cumberland County residents, but people that we house from Perry and the feds, et cetera. So the number of 37 may seem lower, but we have many people who move on to State Correctional Institute or the federals. So.
Yeah, and I guess just to reiterate, this is a required treatment that it's required of the county prison systems to provide MAT treatment.
Well, I think it's also part of just ethically providing a person an MAT, you're to be in treatment. So we very heavily focus on that.
But the MAT program itself, I mean, that's been a requirement of us. Yes.
Yes,
So-
I'm sorry.
Yeah, okay, so yeah,
I absolutely see what you're saying. Yes, we are. If we would be facing many lawsuits if we were not pursuing the program that we have in place.
Thank you.
Yeah, I think your points are wonderful because medical assisted treatment is just that. It's just a tool. The meds are a tool, but our society has made the meds the focus. So I love that Rebecca's saying, and we require the treatment part too, not just the meds, and the meds are required. Yes. Could the county say, but we're not gonna do the treatment part? Probably, without getting in a lot of trouble, I don't know, but some prisons are just giving the meds, so the other piece.
What I found is meds without the treatment, they
Are
just
meds.
come back.
Yeah.
I mean, you can be on an MAT for an opioid addiction or alcohol, and then you can go out and do methamphetamines and be right back. So the two have to go together or it's not successful.
So Rebecca, remind me, I apologize, I forget how long the MAT program has been being done at the prison. Is it 2 years or?
We actually started long ago in 2017 with the food withdrawal program. And that first grant was through the DOC. And then the DOC gave those funds over to PCCD and we continued that. But with all the recent lawsuits, then going up to the Supreme Court of Pennsylvania, it's become more prevalent that you have to offer the different MATs. So we started maintaining people. And then when the opioid funds became available, we were able to start the inductions. So people that come in and need detox, et cetera, we're able to introduce the MAT to them instead of just maintaining people who came in on it.
Okay, so the question that I get often asked in the community is what is the recidivism rate of people? And, you know, you've alluded to the fact that, you know, people that stay in the treatment, you don't see them back through again. Will you be able at some point to provide a lot of data on that?
Yes, we do keep track of that, actually. I just didn't.
No, that's okay, thank you.
I could bring it to the next prison board.
Or the next presentation, that would be fantastic.
Sure.
Thank you.
I think also your point of how do we keep people engaged with race, which wouldn't be the prison's concern, but it can be the specialty courts and probation. And I think we can some of those numbers too, because I think it's really important. If they're just getting the meds and they're likely to pick up again.
Thank you.
Brenda, let me ask a question since we're here. I may be jumping the gun on this, but you had mentioned prevention. Rebecca mentioned prevention. I know there's a panel back here at Lansdowne, but I would like to know more about, I'm looking at this, the breakout, and one of the smallest numbers on here is the amount spent on prevention. And that seems backwards. So I would like to know more about what the actual programming is on prevention. And I know there's things outside of this that are preventative too. So, but could you speak a little bit to that for us and for anybody else listening? Because the reason I ask is the focus is here on the big dollars, and the focus has always been on the big drug companies because they have the big dollars, but they're not holding people down and sticking a needle in their arm either. So there's a chain of events that happens, obviously. So it would seem that prevention would yield a lot of long-term benefits at a lesser cost. So can you speak to that for a little bit?
I think you spoke to it very well. Prevention would, but we need to start young too for prevention. And it's, all systems, the social determinants of health. In Cumberland County, we've had prevention in the schools for many, many years. The funding has stayed straight for 10 years, with the exception of last year. The state did have the art funds and gave a little bit extra. Thank goodness for the separate opioid trust fund, where one of the people that's in the schools is currently being funded. I mean, we are, and this is in the prevention slide, we're getting lots of requests recently. And the number one thing that we found for the needs assessment that the community is saying is not opioids anymore. They're saying vaping, marijuana, and alcohol. What the provider community is saying is the biggest problem is alcohol. It always has been, but the funds are following the opioids. So with all of the different funding we do, it's only a percentage of those programs though too. Like when we talk specialty courts, I'll be sharing, or can I move into specialty courts, or do you want me to keep talking about it? Because I'll be sharing that the numbers of, just like the overdoses are going down, the numbers of the people in systems are going down too that have an opioid history. And Rebecca spoke well to the importance of doing a thorough screening and not just saying, oh, I want the meds while I'm in prison, and stuff. And
I'm sorry, Brenda, but I could make one more mention about prevention. I did a breakdown recently on all of the people that we've ever had in MAT. And in the jail generally, we have about 24 to 25% having a serious mental illness. If you include an SMI that's maybe has the symptoms under control, we're talking 50, 60%. Just in the MAT population, it's 10% higher in both regards. And when we do these in-depth screenings on people and evaluations, cross-cutting DSM-5, et cetera. There's a lot of PTSD that's diagnosed in this population. So I think mental health, as far as speaking to prevention, is very important.
You mentioned PTSD. What type of trauma are we specifically?
Childhood complex trauma.
Okay, thank you.
Brenda, do you mind if I just ask a follow-up question? Just, I think for those of us that review this and discuss this on a regular basis, would it be appropriate to say that a lot of the categories are prevention, but the prevention as outlined in that list are very specific prevention services that you're going to get to a few slides from now? But in terms of providing solutions for prevention, a lot of the other programs that you're talking about today would still fall into that category. Is that an accurate statement?
Once people across the line, the prevention changes to preventing future using and overdoses, which those, we are finding those effective. Even like the student assistance program, they're working with children of people with substance abuse, not necessarily with substance abusers. And that's considered prevention too. I mean, those kids that Rebecca's talking about, if we could have got in early, you know, the social determinants of health too, focusing on those can be.
So as the numbers continue to go down and the fact that the funds that we've received have really been kind of are spanning an 18-year, we're on year 3, but an 18-year period, that would you imagine that, as Commissioner Eichelberger said, prevention is very important, that we will sort of tip the scales and move more towards prevention once the epidemic itself is under control?
I think we'll have funds to do that, more funds, yeah. One of the pieces I was going to talk about with the specialty courts is, as you're aware, that these numbers that we gave you are from January through June, which when we were under the other specialty courts, and we ran the numbers, and it was like for the OID courts, it was 62% of people had some sort of history of OID, of opioid use disorder, and then for the treatment court, 42%. And for Tom's court, the mental health court, 23%. When we moved to the new courts in July, here's the numbers, okay? The Tom's court, the mental health court, went from 23% down to 11%, which is great news that less people are in the courts with opioid use disorder. Now they're in the courts for other reasons. The bad news is we can't pull the opioid trust fund money for those people. 42% of the treatment court folks were that. This is comparing apples to oranges, because now we've got the drug court and 70%, so we can pull more for the drug courts. The DUI court, we don't have anything to compare that to, but only 8%. But like we said, alcohol is our biggest problem. When we measure overdoses across nationally, we don't measure alcohol overdoses because we're so used to it, you know, but they're way over. We did a time study of the people that are working in the courts with the new and the times that they spend with people with opioid use disorder are way down too. So there will, to Stacy's point, be some funds that most likely won't be spent on specialty courts from opioids, which hopefully in the future will be available.
So you mentioned alcohol overdose. What does that look like? Are we talking about someone who has to enter formal rehab? Are we talking about somebody who dies from it, or?
More people die of alcohol way than related illnesses. I'm just talking about alcohol overdose. So with the
Which is what? Yeah. Which is what? That's what I'm asking.
Too much, and it kills you.
So it does result in a death.
It can result in a death. More likely, it's likely to result in let's see, how can I say it? A medical complication that eventually. So you might have liver disease. That's not going to be listed though as an overdose.
Okay.
And it doesn't include accidental death by someone that's.
No, that's not an overdose. It's
Right.
not too much of something. And usually a person with chronic alcoholism, they won't overdose because they built up a tolerance. So it's more likely to be younger folks are inexperienced drinkers.
Withdrawal from alcohol, though, is more dangerous than any other withdrawal.
Really?
More people die in alcohol withdrawal than any other drug, including opioids. You won't die in opioid withdrawal. You'll feel like it's beyond miserable. But alcohol. So that's why with people with alcohol that are using alcohol, if they say, you know, don't quit cold turkey because you're likely to go any drug. The detox is the opposite of that drug. So if alcohol depresses us, you know, it's legal, it depresses us, you know, calms us. The opposite is the shakes, seeing things, the DTs, seizures.
I'm not asking this to be flippant, honestly. So is anybody suing Anheuser-Busch or any of the
We're so
other?
used to it. This is society. We're so used to it. No, I respect you asking these questions. Because we're so used to it.
Well, and Brenda, it's legal. And I know that prescription opioid use was legal, but it got to the point where lots of it was illegal. But this nation, we had prohibition and everyone fought to get alcohol back. I think it's so interesting, Brenda, the points that have been raised today, and Rebecca. And I just go back to these conversations that we have about flat funding for mental health care for the past, 15 years now. And how we can't take care of children and youth that are complex cases because there's just no impetus above us in a government level. And here we are. You know, it's very expensive to take care of things later instead of fixing them at the get-go. I do wonder, as we talk about alcohol, Brenda, and prevention, you know, one of the biggest safety problem that we have in this region with traffic is DUI. So I'm hoping that maybe those things come together with the state and PennDOT and preventing at least DUI related accidents. But it would be a lot less expensive overall for everyone if we could get these three things under control.
And we can add to that healthcare costs too, because alcohol is
Yes.
huge. You know, if we look at our healthcare costs as a nation, most of them can be attributed to some sort of addiction, whether it's alcohol, whether it's food, whether it's nicotine, or mental health issues. So it all weaves together.
I guess that's why I raised the question originally regarding prevention. So when I'm thinking prevention, I think the average person, they're thinking prevention from the first occurrence, just keep people off that track altogether, because there's so much comes with that. You know, if they're on the track, get off the track, get back on the track, and that's a bad cycle. But that would be a lesser problem if you keep people off the track to begin with. So it just surprises me. It seems to receive an inordinately small amount of attention.
And there's concerns with the federal budget. It's going to get even less.
Yeah.
And Brenda,
Thus,
I would say that the last time a prevention campaign was successful was the getting children to never take up smoking. And that took 35 years.
well, and a lot of funds followed that.
Yes.
The nicotine industry really got sued.
Yes.
The other piece, though, is kids are vaping.
Yeah.
And that's the problem now. It's still an addictive process for people, you know.
And everybody was told originally that this is the safe alternative to
Yeah.
cigarettes.
Yeah.
Set ourselves up for that.
Yeah. Marketing is so powerful.
Yes. Yeah.
What we do know is anytime you make a drug available, it's more likely to be abused. Alcohol, legal. Medical marijuana, legal. Marijuana doesn't mean it's a good or bad drug at all, but anytime you make it available, it's more likely to be abused. So that's where the legislature and the consumers need to really jump in and say, do we want this?
So if I may ask, based on that, not that I'm asking you to speculate, but in general, if the if the state government, if the Commonwealth is successful in legalizing marijuana use, for instance, seems to me, I know our former DA used to speak to this, and I agreed on that, not much else, that the DUI problem is going to probably get a lot worse. And all the ancillary problems are going to be a lot worse if you make it easier. So it's somewhat baffling to some of us that the Commonwealth is embracing that as a potential legislative remedy, quote unquote.
Anytime you make anything legal, it's more likely to be abused. So we see a lot of DUIs that are marijuana based already. Yeah, with the medical marijuana or not. I mean, getting a medical marijuana card is very easy to pull. So they're able to make it legal.
Must be, as dispensaries are everywhere. Used to be a guy in the corner, you know. And you got a storefront.
I know we've disrupted your
No, it's good.
progress, but thank you for, you're in this world a lot more than any one of us. And we appreciate you bringing us up to speed on all the different aspects of what you're managing.
Thank you for asking. It's nice to have a commission that's interested. One of the prevention programs that Trust is funding, one of the student assistance people in the schools, completing assessments and equally for prevention, hopefully helping those kids from not crossing the line. One piece I can say about that is the research has said the later we can get people to start using, the less likely there is to be a problem. So even if we can educate kids, you know, that, I mean, most people aren't going to wait till they're 24 with brains fully formed. But if we can hold it off somewhat, it can be really helpful for kids and just the education.
Do they still do, I mean, when I was in elementary school, we had a state police officer came in to, you know, gave us the whole thing on drugs and showed us some graphic photographs and all of that. So do they still do that kind of thing?
Not our prevention part.
Right, but we have to know.
DARE was found to not be real effective because of the fact that hot kids, let's try this, you know. So right now we're focusing on teaching life skills more than don't do this, you know.
I mean, I can speak to that.
Yeah, you
can
can.
mention. DARE actually has shown to have a negative impact, meaning kids are slightly more likely to use the substances. And Brenda had mentioned that the listening session, Jeff Hanley from the Commonwealth Prevention Alliance spoke, and he really advocated for evidence-based programs. Because Exhibit E is very broad. It does talk about allowing prevention. He's really advocating for people to use things that we know that work. And luckily our prevention unit does do things that work. And because we know kids aren't out there picking up opioids, they do teach life skills like making good decisions, having goals, you know, thinking down the road. For the older kids, it's about how these substances impact your brain. Because as Brenda said, if you know, people think vaping's okay. Some kids are thinking marijuana is okay. Those still change your brain and make it more likely for you to be addicted later on. So we just, you know, we kind of talk about that and we do it in age appropriate ways, whatever age that is.
We're down to second grade, right? Multiple minds, you know. And then prevention, I spoke to this slide pretty much already, but the 3 priorities for our county for the next 5 years, according to the surveys and focus groups that we did, are they want help with vaping, with alcohol, and with marijuana. The opioids, they're still there, but not, and then the same is true for Perry County. Naloxone.
Yeah, I just had to update for Cumberland County for the first 6 months of this year. We've given out 692 boxes of naloxone, and there's already been way more than that starting in July. And just different people, it might be individuals from the community, different providers, maybe mental health or drug and alcohol who give it to their clients, first responders, county personnel. We went to the Cumberland County Public Safety Fair. A nurse had contacted me because she was going to halfway houses to do trainings, just various requests. And I feel like we're starting to get more, you know, requests for them.
At one time, wasn't there a shortage or something? So supply.
There might have been, yeah, but luckily that hasn't been.
Okay, so that's just like a one-off type of
thing.
Okay. Because it's used as well in hospital settings and such, so.
Yeah, they're more of a prescription.
Right, I would be worried.
Or EMS, but it's different.
It is different.
than what we're giving out.
Okay.
So,
So it's not gonna impinge on the needs of hospitals to have it.
no, in fact, if you give naloxone, you still need to get people to the hospital because eventually the opioids will come back in the brain and they could die. They could like have a second overdose from that. So
Thanks.
we are doing a Save a Life Day, September 25th, I think. So we'll be in Veterans Park, and then also Perry County, several places throughout the county. Just on the street corners, handing out naloxone. So for folks trying to get it out there. And last but not least, just a summary, and Ryan's got a handout for you about the settlement funds. They have been committed through 2028, but we're not sure exactly what's going to be coming down the pike, but we will be before you again to bring forward ideas and get your input and decisions on doing that. So.
Thanks, Ryan. Brenda, a couple of questions I had regarding the trust. It seemed like at the onset of this, people were asking the trust, will this be covered? Will this be okay to use the funds for? And there seemed to be either no response or, well, submit it and we'll tell you kind of thing. So has that gotten better with the trust? Have they become more, I don't want to say definite, but has there been any clarity on some of those things?
Morgan's at the trust meetings and.
Okay.
Yes.
Yeah, I tune in to watch them, and they did say with the last report, with each report, more and more programs are getting approved, and there's less and less disputes that happen. They still have the stance, like if we were to develop a new program, we still could not ask them, would this be approved? They do have, I think it's called Technical Assistance Committee, where you can present it and they can kind of ask you questions that you might be faced with. They're still not going to give you a yes or no. But there does seem to be learning, whether it's the part of the counties or the trusts, that people are kind of getting on the same page about having a sense of what might or might not be approved.
Okay. So that will make it a bit easier, I think, as everybody begins to move forward with programming. And the other question then I had too, when you speak to opioid deaths, is it capturing perhaps someone that got one of those fake pills that had fentanyl in it, and so it was clearly was not their intent to overdose, but they've never experienced fentanyl or something like that? Is there a percentage of these opioid deaths that, while they're all accidental, that are fentanyl based, people completely did not expect that they were taking fentanyl?
Because you don't know what's on the streets. Absolutely, absolutely. So, and very few would be, I mean, it would be considered, if there's like a suicide note or something, they would be classified as a suicide, but otherwise it would be classified as an overdose death.
Just overdose, okay.
Or if someone said, I'm gonna take a ton of this so I can kill myself, that's different than what's being measured right now. In Cumberland County, the exact number, I think it was 19, I said so far this year. The coroner said they were fentanyl and cocaine mostly. So they're overdose deaths, not necessarily opioid deaths. And then some amphetamines, which would be like nothing. So, but no measurements of alcohol because they wouldn't end up with the coroner. So
scary.
It is. It's tragic. We're a nation of addiction. It's true. But we in Cumberland have some ways out of addiction. If people are willing, when people.
Very good. Did anyone else on the team want to, Ryan, did you want to speak to the numbers at all, or is this just more for our knowledge and planning, or?
This is just more of a overview of sort of what we're looking at currently. Everything beyond 2025 is an estimate based off of a decent guess. the trust, whenever they actually pay, one of the waves is when we find out how much we're actually getting. They give us an estimate, but between the time they give us the estimate and when we actually get the check, that number has changed. So they gave us an estimate for 2026, and that's what's on here, but it's likely that will be slightly different, less than $100, but every time it's been different. So, and then the expenses are just sort of based off of time studies and a good estimate of what the programs are going to cost, and then averaged out across several years. So.
Thank you for all your work on this. I know it's not because of, as you've described, Brenda, the folks that you're assisting, they have so many different issues that they may be managing. It makes it very challenging to know and what qualifies as an opioid. So thank you for getting to that data so that these funds can be used for that purpose. So appreciate that. Commissioner Fashi, did you have any questions you wanted to ask?
I do not.
Okay. Were there any other?
Let me ask one quick thing, Brenda. We were told years ago, I can't remember the exact number, but we were told there's an average number of occurrences that person typically goes through. I mean, what I mean is the number of times they have to go through drug rehab or to actually take. Do we have a number on that?
You don't, and the numbers that we would get as a county are very different than the national numbers too, because a lot of folks have treatment, but they have resources too, so they can afford to go, to the outpatient, and they've got families. I mean, the social determinants of health are huge in recovery rate, if you will. So we don't have that, but like many people are out there working, and you don't even that they have a history of addiction. I was just at the RV show this weekend and was talking with a man, and he said he was from Iowa and their company was from Iowa, and the salesperson there, and I said, oh, where are you from? In Iowa, we used to live there. And he said, yeah, Sheldon. I said, oh yeah, the company I worked for, we had an office there, and nice area, we love living there. And he said, who'd you work for? And I worked in addiction, of course, and I told him, and he said, I got sober there in 1988. Would that man show up in any statistics? Absolutely not. He's working, he's doing life, he's a taxpayer, he's, so I appreciate that we did Recovery Month, because there's so many people out of the system we don't even know about, but this is a way to at least support them. So thank you for asking. We could probably run the numbers of the people that we see in case management, which is such a small sample, but they're the ones that count people in the state.
Thank you. Thank you very much. Thank you all. If no one else has anything they want to add to the discussion.
I just wanted to say something. I'm Ashley. I'm from the Criminal Justice Services. Erin wasn't able to be here, so she sent me over if you guys had anything to add on with any of the specialty courts. But she wanted me to piggyback and highlight about the specialty court ending their $168,000 contract with our CRS. That research has found that CRSs are offered in our drug and alcohol providers free base, and allows participants to build their recovery capital. So we're able to free those funds to how those funds go somewhere else. So she just really wanted to highlight that you guys were aware of that. And
thank you for pointing that out. That's I had heard rumor that she was finding some things like that. So it's wonderful that when the teams are working together and we're not duplicating services or paying for things that can be free elsewhere.
Yes.
So thank you so much.
Thank you for speaking out, Pastor.
yeah, you're welcome.
It's a wonderful change. Getting people out in the community, not in the courts.
Agreed. All right. Is there any other business to come before the board at this time? Hearing none, seeing nothing, we'll entertain a motion for adjournment.
Move to adjourn.
We are adjourned. Thank you all very much. Brenda.